Hello everybody. Today we discuss a very important topic in critical care medicine, that is acute pancreatitis. This is important not only just clinical point of view but also in your everyday practice, where you will frequently encounter a case of pancreatitis, and the treatment as such may appear simple, but it is associated with huge morbidity and mortality. So we will be dealing under definition, etiology, cause in pancreatitis, grades and prognostications, investigations, goals of management, surgical intervention and the management of complications. Please remember, this is a very important topic as it is a very frequent question which is seen in any of the DM exams or DRNB exams or even in your IDCCM exams. So let's begin with definition. What is acute pancreatitis? It is an inflammatory condition of the pancreas which is most commonly, we believe, either caused due to the gallstones or excessive use of alcohol. So what does IAP or APA, that is International Association of Pancreatology or American Pancreatology Association, define pancreatitis as? It defines as pancreatitis as basic fulfillment of two criteria. As we all know, patient comes with a pain abdomen, and whenever patient comes with a pain abdomen, we first think of pancreatitis, especially in the background history of alcoholism, and we try to do amylase and lipase, wherein if we find the serum amylase or lipase level more than 3 times the upper limit, then if we happen to do an imaging either in the form of ultrasound or CT or MRI. So the IAP or APA defines as 2 of the 3 criteria should be fulfilled, that is either the upper abdominal pain with an increased amylase or lipase or a radiological imaging which is showing us that there is an inflammation of the pancreas. And this is a grade 1B recommendation which has got a strong agreement. So etiology. Etiology you all must be very clearly knowing. 2 main important etiologies, gallstone pancreatitis, alcoholic pancreatitis. Both of them more or less equal. Some believe that in the west it is more of alcoholic pancreatitis followed by gallstone, and in the east it is more of gallstone pancreatitis followed by alcohol. But almost 30 to 40% of the times we do not have an etiology and we term it as idiopathic pancreatitis. Other than that, family history of pancreatitis or usage of drugs like azathioprine, cyclosporin, valproic acid, infective pancreatitis, hypertriglyceridemia, or any history of pancreatic tumors or corticosteroid use, sulfa abuse, drugs or hepatitis A, B infection, Coxsackie infection, mumps virus infection, or a post-ERCP pancreatitis, traumatic pancreatitis also do form other common etiologies. This is very important, especially when we approach for a treatment, because the source control also forms an important aspect of treatment here, and as well as a theory point of view. Grading and severity. So as we already discussed that pancreatitis is associated with high mortality and morbidity. So grading of a pancreatitis at the admission as well as 48 hours post admission becomes very crucial. So we have 2 types of classification here, revised Atlanta classification and determinant based classification, which divides pancreatitis into mild, moderate, severe, whereas in determinant based classification we have an extra criteria which is a critical. So mild, as we know, it's a mild pancreatitis wherein patient presents with to us with an abdominal pain with an increase in enzymes, that is amylase or lipase, but there are no organ failure, no local complications, no systemic complications, and typically the pain and enzyme levels resolve within the first week. So both for RAC and DBC it is the same. Whereas in moderate there is a transient organic failure. Now what do you mean by transient organic failure? There is an organic failure either in the form of decreased P/F ratio in an ABG which is causing some acute lung injury, or there is a small amount of acute kidney injury, or you have a small amount of hypotension. But this is transient, that is this organ failure usually more or less reverts back in 48 hours. The same thing is for determinant based classification, wherein they mention that there is some amount of sterile pancreatic or peripancreatic complication, that is a local complication with a transient organic failure. Whereas in severe classification we have not only a local complication but we even have a persistent organ failure going beyond 48 hours. When we come to determinant based classification, there is one more extra criteria, that is critical, in which there is definitely an infectious pancreatic or peripancreatic complication, that is there is a pancreatic complication which is most probably assumed to be infectious followed by a persistent organ failure. So why do we need to remember all these things is because this is very important, especially in Viva as well as in the theory answer. Scoring in acute pancreatitis is again a very important question both in theory and practical. I know there are numerous scorings present. Like here itself we have mentioned some 7-8 scorings. We have Raaonline score, we have BISAP score, Harmless pancreatitis score, Glasgow-Emery score, CIS response, Apache score, CT severity index. Then we have a Japanese score. There are a lot of scores. And to remember these scorings with all the criteria is definitely inhumanly impossible. So at least try to remember some 2-3 important scores, and the characteristics of these scores or the criteria for these scores. Like for example, Raaonline's criteria is you have it at admission and at 48 hours, and there are two different for gallstone pancreatitis and non-gallstone pancreatitis. So generally what do we see? At admission we try to assess the age of the patient, his WBC count, the blood glucose level, LDH and AST levels. And at 48 hours after admission, we have the fall in the hematocrit, the bun elevation, the base deficit, the fluid sequestration, arterial PO2 and serum calcium levels. Similarly, for a gallstone pancreatitis, the same criteria, but the characteristics of the criteria might matter. Like for an non-gallstone pancreatitis, the WBC is more than 16,000, whereas here it is more than 18,000. The sugar levels has to be a little higher. Similarly, for LDH and AST, they are more or less higher here, whereas by the 48 hours post admission we have more or less the same criteria for everyone, except for the fluid sequestration, which is 4 liters in acute gallstone pancreatitis and 6 liters in non-gallstone pancreatitis. BISAP scoring. This is one of the very important scoring because it's a bedside scoring, bedside index for severity of acute pancreatitis, which we also do in day-to-day practice, and it is a very simpler scoring. So we better remember it. BISAP, the mnemonic stands for BUN more than 25 mg per dl, impaired mental status, systemic inflammatory response syndrome, altered mental status and pleural effusion. So each parameter here is given 1 point. So if we get a score of less than 2, the mortality is assumed to be around 0 to 0.5%. The score of 2 is equal to more than 2% of mortality, and score of 3 is equal to almost 20% mortality. Then we have Balthazar scoring, which is based upon the CT imaging and the local pancreatic complications. Like for a normal pancreas, we have a 0 points. Pancreatic enlargement, we have 1 point. The peripancreatic inflammation of fat, if there is a peripancreatic fat, we have 2 points. Fluid collection, 3 points, and 2 or more fluid collection or air seen in the CT imaging, we have 4 points. Then based on that CT imaging, we try to grade how much of necrosis is present. No necrosis, 0 points, less than 30% necrosis, 2 points, 30 to 50% necrosis, 4 points, and more than 50% necrosis, 6 points. So based on this Balthazar scores, we come to a CT severity index, which is the total score between the imaging of the pancreas as well as the necrosis changes present in the pancreas. We get a CT severity score, which is, if it is 0 to 3, it's a low degree mortality. If the score is around 4 to 6, we have 6% mortality. But if the score goes to around 10, we have around 17% mortality. Then another very important score, which is a favorite among examiners, that is the Harmless pancreatitis score or HAP score, Harmless acute pancreatitis score. This has got 3 parameters, wherein no signs of peritonitis, normal creatinine and hematocrit less than 44. So you have these 3 parameters, each parameter having a score of 1. If you get a severe score of 0, it's a non-severe pancreatitis, and at least a score of 1, it's a severe pancreatitis. So this is much more easy to remember. Then we have a Glasgow-Emery score, wherein the mnemonic is pancreas, PO2, age, neutrophils, calcium, renal function, enzymes, albumin and sugar, that is PANCREAS, the pancreas. So remember these parameters, and always remember 3 or more of the below in the first 48 hours indicates a severe pancreatitis. So these are about the scores. Generally try to remember some 2-3 scores, at least the Raaonline score. Then you try to remember the BISAP score, the Harmless acute pancreatitis score. You can always quote Apache score, which is one of the most famous score, which is used in acute pancreatitis as well as in any other ICU admission or any other disease related to ICU admission. So try to remember these 4 scores. Other than that, the World Surgical Emergency Guidelines also gives us prognosticating indicators for prognosticating of acute pancreatitis. Like on admission, if you can prognosticate if the CRP level is more than 150 milligram per DL on admission or a third day, with a hematocrit of more than 44% and a urea of more than 20 milligram per DL. So all these things are independent predictor of mortality. Any of the one present will either indicate an acute severe pancreatitis or it is a direct mortality predictor. And if the procalcitonin is level, it appears to be a strong negative predictor of infected pancreases. And this gets us grade 2A recommendation. So I have tried to cover most of it, but probably I must have missed a few things. One is symptomatology of pancreatitis. You must be knowing it. Pain abdomen. Patient comes with a very severe pain abdomen. Try to bend forward to relieve the pain. Then you have famous Cullen's sign, and you have a Gray Turner's sign for acute pancreatitis, which is very important surgical side of point of view. So Cullen's sign, Gray Turner's sign. Other than then we have increase in the serum amylase lipase. Pathophysiology of pancreas, we all will be knowing. It is the instigating factor causing inflammatory damage in the SNR cells, and there is a release of toxic granules from the zymogen, and all the pancreatic enzymes are released, which causes autodigestion of the pancreas. So it is like a self-destruction of the pancreas. So how do we investigate pancreas? Most of the time it is symptomatology. If patient complains of pain abdomen, typically after an alcoholic binge, or in the background of gallstone pancreatitis, or if a patient has been using some chemotherapeutic drugs, or on an investigation if you find some triglyceride levels high. So that forms a very important thing. And then serum pancreatic enzymes, that is amylase lipase and a newer one called trypsinogen, forms the cardinal indicators for judging acute pancreatitis. So we have amylase, we have lipase, and we have trypsinogen, out of which amylase is considered to be a sensitive enzyme but not very specific, because amylase is not only released by the pancreas, it is also secreted by the salivary glands, ovaries, adipose tissue, skeletal muscle and intestine. So it becomes a sort of non-specific, because if you have a salivary gland tumor, or if you are pregnant, in pregnancy it is released, or if you have some PCOD problems, or in an obese patient, or a muscle injury, there is always an increased level of amylase. Whereas if you go for lipase, it's a highly specific enzyme and the sensitivity is also quite high, which has got a large diagnostic window. That is, it rises in 4 to 8 hours, peaks at 24 hours, and the levels usually fall down by 8 to 14 days only. Then there is another enzyme called trypsinogen, which now it has not come into the guidelines yet, but probably this can also be considered as a marker for diagnosing pancreatitis. And the advantage of this trypsinogen level is it rises very fast, that is in few hours, and it can be measured both in serum as well as urinary trypsinogen levels, but it tends to fall down within 72 hours. Radiological imaging, definitely very important. Most of the pancreatitis are diagnosed through radiological imaging only. So on admission, we get an ultrasound which determines especially to determine the etiology of acute pancreatitis, that is the biliary etiology, and that gets a grade 1C recommendation. But whenever, if you are in doubt, because pancreas being a retroperitoneal organ and not being visualized radiologically so well, so CT can also be reliable. But beyond ultrasound and CT, if you think like you have a diagnostic uncertainty, or in spite of diagnosing acute pancreatitis, there is no proper response to treatment, or there is a persistent organ failure and you want to grade the pancreatitis, then a CECT or an MRI can also be done, and the optimal time as per the IAP or APA guidelines is 72 to 96 hours after the onset of symptoms. In addition to that, if you think there is an etiology of biliary pancreatitis, an MRC or endoscopic ultrasound can also be done to screen for occult choledocholithiasis, and that's a grade 1C recommendation. Remember, all these are grade 1 recommendation, that is ultrasound at admission, at 72 to 96 hours getting a CECT or MRI done in case of diagnostic uncertainty or poor prognosis or prognostication, or in the background of having a doubt of occult choledocholithiasis or biliary pancreatitis, an MRCP or endoscopic ultrasound. So treatment principles, as I always tell, always begin your answer with the word goals of management, which creates a very good impression for the examiner, as well as in your viva voces. So that makes the opposite person know that okay, you know about the subject and you know what are you going to do next. So what are our goals of management here? Definitely fluid therapy. We know that there is no great pharmacological treatment of pancreatitis. It is basically rest to the pancreas, fluids, treatment of dehydration and treatment of the other peripancreatic and local pancreatic complications, as well as giving analgesic control or analgesia to the patient, because pancreas is associated with severe pain and pain is in turn associated with increase in inflammatory markers. So our goals of management here will be fluid therapy, of course, pain control, the withdrawal of the instigating factor, like if it is a biliary cholangitis, it has to be treated, or if you think it is a mild pancreatitis with gallstone, then cholecystectomy or withdrawal of the offending drug, or if it is a hypercalcemia induced pancreatitis, then prevention of the complications and early rehabilitation and nutritional support. So this is very important because we often tend to keep pancreatitis patient on nil orally for very long days. Olden days they were kept nil per oral for almost 7 to 10 days, which might lead to other complications like malnutrition, dehydration, protein energy loss and other things. So early rehabilitation and nutritional support is also our first goal of management here. So it's not like every pancreatitis patient has to be admitted to ICU. It can be very well managed in the ward also if it is a RAC grade 1 or our DBC grade 1, that is the mild pancreatitis without any organ failure. So there are certain indications wherein the patient should be admitted to ICU in a background of pancreatitis. So as per SCCM guidelines, the usual indications, any patient having the pulse rate less than 40, more than 150, or if you think he is hemodynamically unstable and unable to maintain a MAP of more than 60-65, the patient is tachypneic in distress, dyselectrolytemia with very high or very low sodiums or high or low potassium, patient is in hypoxia, acidosis, or the glucose levels being very high or low, calcium levels being very high, or anuria or coma, or GCS less than 8. In addition to this, the revised Atlanta classification also says that severe acute pancreatitis has to be treated in ICU. So let's go to our first goal of management, that is fluid resuscitation. So fluid resuscitation forms very important part of treatment here, and especially fluid resuscitation in the first 48 hours is very important because it not only helps to maintain the tissue perfusion but also improves the microcirculation in the pancreas, which forms a very important thing in healing of the pancreas. So when it comes to fluid, we always have to address what fluid are you going to give, at what dose are you going to give, for how long are you going to give, and at what time are you going to de-escalate, and what is going to be your judge or basis for escalation or de-escalation of fluid. So definitely isotonic crystalloids are preferred, especially in pancreas. Small studies with a weak evidence says that ringer lactate is much more preferable to normal saline for its anti-inflammatory effect. But other than this, we always know we have got a lot of studies on fluids, from SMART trial, split trial to the most recent basic and plus trial, which always say that isotonic crystalloids in the form of ringer lactate or plasmalite are more preferable in ICU because there are chances of a hyperchloremic metabolic acidosis or acute kidney injury when you cross loading the patient with normal saline above 2 liters. So 100% isotonic crystalloids. At what dose are you going to give the fluid? Again, we have lot of studies here with high volume resuscitation, low volume resuscitation, or a bolus followed by a low volume resuscitation. So lot of studies, including a very important recently published study called as waterfall study, has showed that low volume resuscitation is always safer, and it is not high volume resuscitation is associated with mortality. In fact, this study was terminated because they found that the high volume resuscitation is associated with mortality. So when it comes to pancreatitis, always at the dose of 5 to 10 ml per kg per hour, but this one word of 5 to 10 ml per kg per hour does not define for every patient. Definitely in the background of acute kidney injury, in the background of severe LV systolic dysfunction, or in a respiratory distress, you always have to guide your fluid management based on your hemodynamic assessment. So what hemodynamic assessment? That again is a big topic, but in general, you try to check from your clinical point of view, from your urine output, your MAP, your base excess, your increasing trend of lactate levels, Then judge your IVC collapsing or distensibility index. If you have gadgets like stroke volume variation or pulse pressure variation, you can always use them. If the patient is on ventilator, you can try a tidal volume challenge, or you can do an ultrasound lung to check for B lines. And based on all those things, all these hemodynamic assessments, try to upgrade your fluid up and down, but make sure that you do not give a higher volume resuscitation. Give a minimal resuscitation of around 5 to 10 ml per kg per hour, and especially within 48 hours, because fluid overload is detrimental. Pain management. So pain, very important, even from patient's psychological point of view, as well as we know that pain helps to reduce inflammatory markers and the inflammation. Other than that, if the patient is able to breathe properly without pain, the chances of him aspirating pulmonary atelectasis, basal pneumonias, everything is less. And if the pain is under control, it is very easy to mobilize the patient and avoid other complications like deep venous thrombosis, bed sores and other things. So how do we treat pain? Patient controlled analgesia is the most preferred. Avoid NSAIDs for the first, because acute kidney injury is one of the most common complication in pancreatitis, either secondary to the inflammation or sepsis or because of a fluid overload. So avoid NSAIDs. The best will be a paracetamol based analgesia, especially 1 gram paracetamol, make it 8 hourly or 6 hourly based on patient pain scores, or a non-opioid based analgesia in the form of tramadol will also be preferable. Opioid based agents, controversial, because in a patient it can even cause respiratory suppression or even decrease intestinal motility. But newer agents like dexmedetomidine, which promises us conscious sedation, analgesia and amnesia, would be definitely preferable. Or in very refractory cases where the pain is very much intolerant, an epidural analgesia can also be given. Nutrition, as I said earlier, it was believed that pancreatitis has to be kept nil per orally for almost 7 to 10 days. So it was like 7 to 10 days patient was devoid of his basic right, that is his nutrition. But now the newer guidelines has changed, the newer modalities of treatment have changed, and it advocates that in a mild pancreatitis, start oral feeding as early as possible. If the patient, the dictum is, if the patient complains of hunger, feed him. If the patient says there is decrease in the pain intensity and desires to have food, feed him, because the decrease in the pain intensity or the patient's desire to have food or hunger or satiety itself is an indirect indication that the inflammatory markers are coming down and the pancreas is as such healing. So in a mild pancreatitis, though it's a grade 2B recommendation, but definitely it has got a strong agreement. Oral feeding has to be restarted once your pain decreases and inflammatory markers improve. In a severe pancreatitis, feeding has to be started. Either it can be in a form of enteral feeding or parenteral feeding, but definitely enteral feeding is preferred. As we all know, enteral feeding will maintain the normal physiological function of the intestine. It will maintain the gut motility. It prevents the translocation of the bacteria, and it even prevents other secondary infections and maintains the gut mucosal barrier. So enteral feeding, either in the form of elemental feed or polymeric feed, can be a primary therapy. Then parenteral nutrition. Some might question like, why not initiate parenteral nutrition and give total rest to the pancreas? But parenteral nutrition, though nowadays studies say that both enteral nutrition and parenteral nutrition are equal, parenteral nutrition is not associated with more chances of infection. But I would suggest that initiate parenteral nutrition in your ICU into any patient only on 2 conditions. If you think that you are not able to initiate enteral nutrition within a week time, for example in a large bowel surgeries wherein you have only a small amount of bowel left, or in a gangrene of bowel, you cannot initiate enteral nutrition within estimated 7 days, definitely initiate your parenteral nutrition. Or in spite of initiating your enteral nutrition, you are not able to meet the caloric requirements for that particular patient, especially not able to meet your 2/3 of your basic caloric goals, then you have to initiate parenteral nutrition. And this form of parenteral nutrition is called PPN, that is partial parenteral nutrition. Then nasojejunal route or nasoenteric route. So some might argue that nasojejunal route is more preferable because it bypasses the pancreas, but studies, especially the high graded RCTs, do not give any superiority of nasoenteric feed over the nasojejunal feed, except for a weak base of evidence which says that nasojejunal route can be preferable more than the nasoenteric food. But if you think that there is no access to give a placement of a nasojejunal RT because it requires either a fluoroscopic or endoscopic guidance, then nasoenteric feeding through nasoenteral route is also equally safer and does not cause any harm to your patient as compared to your nasojejunal route. Surgical and operative management. As I already said that no great pharmacological treatment we have for an acute pancreatitis. We do not have a drug we think like we can give for acute pancreatitis to subside the inflammation. So it is rest to the bowel, fluid management, analgesic management, as well as your nutrition. Other than that, there are certain places wherein we think that if a surgical intervention is done, probably the pancreas can be healed and the inflammation can be resolved. So where all you think the surgical intervention has to be done. So in a patient where you suspect a gallstone pancreatitis, routine ERCP is not required. ERCP in a patient with gallstone pancreatitis is recommended only if there is a cholangitis. In the absence of cholangitis, doing a routine ERCP for a gallstone pancreatitis might do more harm in the form of post-ERCP pancreatitis and might inflame the pancreas all the more. So, in a patient with gallstone pancreatitis with the increased SGOT, SGPT or alkaline phosphatase levels, wherein you think there is cholangitis, definitely ERCP is indicated. And this gets a grade 1 recommendation. In an ERCP, in an acute gallstone pancreatitis with common bile duct obstruction is also indicated. And ERCP in patients with predicted severe acute gallstone pancreatitis without cholangitis or common bile duct obstruction cannot be recommended. So, no CBD obstruction, no cholangitis, but an ultrasound shows that there is a gallstone and you have an inflammatory lipase amylase raised more than 3 times of your normal, indicating pancreatitis, but do not jump in and get an ERCP done. Then, percutaneous or endoscopic drainage of pancreatic collections. So, in some instances, in spite of our fluid therapy or analgesic management, giving rest to the pancreas, there is clinical deterioration of the patient, especially in a patient who has got a local complications of the pancreas, like in the form of a pancreatic pseudocyst, pancreatic abscess, or there is a gastric outlet obstruction because of the pancreatic pseudocyst, or there is a biliary intestinal obstruction, there is an increase in the size of the pancreatic pseudocyst, there is an ongoing organ failure, or there is a disconnected duct syndrome. In all these places, the patient definitely does not improve and will be having persistent organ failure. There is a need to intervene surgically. But if at all, if you think all these indications are present and if you have to intervene surgically, it has to be done either through percutaneous or endoscopic drainage, that is minimally invasive procedures, not through any open procedures which might give you more harm than benefit. So, these procedures can be done within 4 weeks, wherein you can percutaneously or endoscopically approach the pancreas and try to drain the abscess or try to drain the pseudocyst or relieve the obstruction or try to open the duct which is disconnected. Other than that, if it is like onset of pancreas has happened and it is beyond 8 weeks and still the patient is having the ongoing pain, discomfort with some amount of persisting organ failure, definitely a surgical intervention in the form of percutaneous endoscopic drainage can be done. Beyond this, you have crossed your 4 weeks and still the patient does not seem to be improving. The patient seems to be worsening in the form of either abdominal compartment syndrome or bowel fistula with extra pancreatic collections, and you have even tried your endoscopic or endovascular approach and you were unsuccessful. The organ failure is persisting, patient is developing into shock, MODS, there is a bowel ischemia. Definitely surgical intervention has to happen. But in most of the studies and most of the guidelines do say that in such indications it is as much as possible to postpone the surgical interventions for more than 4 weeks after the onset of the disease. Because it has been shown in many of the studies that postponing surgical intervention beyond 4 weeks definitely results in less mortality. So here we come term called abdominal compartment syndrome. I'll explain you what is abdominal compartment syndrome in my next slides, because it's a very important topic. It's a big topic. I had tried to explain it in short. We'll have another class on it. So, in general, surgical intervention, whenever if possible, have a percutaneous approach or an endoscopic approach, either in the form of transgastric endoscopic approach, which is a minimally invasive approach, or a video assisted retroperitoneal debridement. If these three things can be done in less than 4 weeks duration, but beyond this also, if the patient does not seem to be improving, there is a persistent organ failure and you think the necrosis is increasing, then definitely patient has to undergo a surgical necrosectomy, and ideal time to have a surgical necrosectomy will be beyond 4 weeks, because this time limit beyond 4 weeks has been conferred to improve mortality. Index cholecystectomy. So, this is a special term which has been given especially in the background of pancreatitis, that is cholecystectomy during that particular admission, especially in a patient in whom we suspect a gallstone pancreatitis. So, definitely laparoscopic cholecystectomy during that admission for a patient presenting to pancreatitis can be done, especially if the pancreatitis is a mild pancreatitis, that is a mild acute gallstone pancreatitis. A laparoscopic cholecystectomy is advocated, and remember, this is a grade 1 recommendation. Then when ERCP and sphincterotomy are performed during the index admission, the risk of recurrent pancreatitis is diminished. In that cases, index cholecystectomy is more preferable to prevent the biliary complications. In other situations wherein you have a acute severe gallstone pancreatitis with some peripancreatic fluid collections, it is better to defer your cholecystectomy beyond 4 weeks until unless your inflammation subsides and your fluid collection resolves. But if you think it's an acute gallstone pancreatitis, that too a milder variant of pancreatitis without organ failure, without any peripancreatic collections or inflammations or abscess, then index cholecystectomy, that is cholecystectomy in that index admission, is definitely advocated. Management of complications. So, pancreatitis is basically associated with one array of complications which you can tell in the form of local complications or systemic complications. So, when it comes to local complications, we have a pseudocyst formation, we have a inflammation of the pancreas forming a peripancreatic collections, we have necrosis of the pancreas, which can be sterile necrosis or an infected necrosis, we have formation of pancreatic abscess, pancreatic fistulas, bowel ischemias, disconnected duct syndrome, and lot more. Other than that, pancreatitis is also associated with systemic complications like acute kidney injury, ARDS, that is respiratory distress syndrome. We have septic shock, we get various kinds of infections and pneumonias, ventilator associated pneumonias and other things. Because pancreatitis is associated with one long stay of the hospital and high mortality, there are a lot of complications associated with it. So, here we will try to see a small hint about what is intra-abdominal pressure and abdominal compartment syndrome, because pancreatitis forms one of the very most common etiology of an increased intra-abdominal pressure or intra-abdominal hypertension. So, what is IAP? IAP is a steady state pressure which is concealed within the abdominal cavity. So, there is some amount of pressure which is always there inside the abdominal cavity, which is usually around 5 to 7 mm of Hg. And how do you measure IAP? It is measured by using a 3-way Foley's catheter. It is usually expressed in terms of millimeters of mercury and is measured at end expiration of the patient in supine position after ensuring that the transducer is at the level of the mid-axillary line. So, here you see IAP is approximately around 5 to 7 mm of Hg. Beyond 12 mm of Hg, if your intra-abdominal pressure goes beyond 12 mm of Hg, then we confer it as intra-abdominal hypertension, that is IAH. So, that means there is a pressure building up inside your abdominal cavity and the pressure has gone beyond your limit of 5 to 7 mm of Hg and has reached to 12 mm of Hg. Based on that, IAH is graded into 4 categories, that is grade 1, grade 2, grade 3 and grade 4. The grade 1 is around IAP being around 12 to 15 mm of Hg. Grade 2 is 16 to 20 mm of Hg. Grade 3 is 21 to 25 and grade 4 is more than 25 millimeters of mercury. So, When your grades keep on increasing, we get another term called Abdominal Compartment Syndrome, that is ACS. Here ACS is defined as a sustained increase in IAP, intra-abdominal pressure, beyond 20 mm of Hg, and it is associated with a new organ dysfunction or a failure. That is, there is a pressure building up in the abdomen which is definitely beyond 20 mm of Hg and it is sustained at 20 mm of Hg. Plus, it is associated with a new organ failure like a bowel ischemia, gangrene, acute kidney injury or a respiratory distress. So, a single organ failure is mandatory. When you come to that terms, it is called as abdominal compartment syndrome. Here, I will try to explain you how do we measure your intra-abdominal pressure. So, with the patient in supine position, we place a 3-ways Foley catheter, a specialized catheter, and then we clamp the Foley's catheter. The bulb is specifically instilled with 20 to 25 ml of your normal saline or distilled water, and when you clamp it, the bag is connected here. This is the bulb is instilled, and then we clamp the Foley's here, and this is connected to a transducer which is kept at your mid axillary line. Some people also believe that it is kept at your intersacral level, that is between the intersacrum level, and then it is connected to a pressure transducer and measured in the monitor. And the normal pressure being 5 to 7 mm of Hg, beyond 12 mm of Hg, it is called as intra-abdominal hypertension. So, what are the organ dysfunctions we can see with an abdominal compartment syndrome? So, this abdominal compartment syndrome is associated with almost every organ dysfunction. Like you see here, in if CNS, it is associated with raised ICP and decreased cerebral perfusion pressure. When it comes to lungs, the compliance of the lung decreases, the peak inspiratory pressure decreases, you have hypoxia, hypercapnia, shunt fraction increases, there is basal atelectasis. When it comes to cardiovascular system, the cardiac output decreases, the venous return decreases, there is an increase in stroke volume resistance, pulmonary vascular resistance, increase in your CVP. When it comes to your kidneys, there is decrease in the renal blood flow which will cause decrease in your GFR and decrease in the urine output. In your gastrointestinal system, there is decrease in the celiac blood flow, mesenteric blood flow, mucosal blood flow. It can result in bowel ischemia and gangrene. In addition to that, in your thoracoabdominal system, the chest wall compliance is decreased, the abdominal wall compliance is decreased, there is an increase in intrathoracic pressure, the IVC is distorted, and a patient finds it very difficult even to breathe. So, how do you manage this intra-abdominal hypertension or abdominal compartment syndrome? Here, your goal of management will be to relieve the pressure. You have to relieve the abdominal compartment pressure, and we definitely know that this intra-abdominal pressure is secondary to another pathology which can be either because of the gangrenous bowel or your acute pancreatitis, or because the secondary to burns or your fluid overload. So, definitely the fluids have to be controlled. Pancreatitis, fluid is the treatment of choice, but when we think that there is third spacing and there is a rise in the abdominal pressure, there has to be a limitation of the fluids and vasoactive drugs to achieve our resuscitative goals. In addition to that, deep sedation and paralysis can also be done to reduce or limit the intra-abdominal hypertension. Percutaneous drainage of your intraperitoneal fluids is mandatory, or before performing, you can even go for a surgical decompression, but before a surgical decompression, definitely a minimally invasive approach is mandatory. Placement of a Ryle's tube, placement of the flatus tube to decompress the abdomen also forms a treatment. Second complication of acute pancreatitis here would be mechanical ventilation. So, as the patient presents to us with pain results in distress, and with our aggressive fluid management resulting in fluid overload, most of our acute pancreatitis patients, when they come out to us within that cytokine storm with an increased SIRS response, they result in distress and resulting in tiring of respiratory muscles, going into hypoxia, hypercapnia, and in such situations, this is one place where mechanical ventilation gives an upper hand to the non-invasive ventilation. Because non-invasive ventilation, again, is associated with aspiration, increase in abdominal pressure, gaseous abdomen and other things. So, whenever you think a pancreatitis patient is landing into respiratory distress, do not hesitate to institute mechanical ventilation. Have a lower threshold to institute mechanical ventilation in them. And once mechanical ventilation instituted, we all know lung protective ventilation, that is as per ARMA trial, low tidal volume ventilation has to be instituted. Antibiotics in pancreatitis. So this forms the most controversial topic in pancreatitis, that is whether antibiotics has to be initiated or not. As we all know, pancreatitis is a systemic inflammatory response syndrome and it is always associated with persistent fever, which will give us a confusion whether the fever is secondary to SIRS or secondary to the infection. Then we see an increased TC, total count levels in pancreatitis. That again is another SIRS response, so again another confusion. In addition to this, there is an increased CRP, increased erythrocyte sedimentation rate. There is a mild increase in procalcitonin in pancreatitis, as well as there is a vasodilatory shock secondary to SIRS. So all this combined gives us a clinical picture of a sepsis. But always remember, pancreatitis, at least in the first 7 days or maximum to first 72 hours to 7 days is an inflammatory response. So routine usage of prophylactic antibiotics in pancreatitis is definitely not suggested, and it's a grade 1A recommendation that usage of antibiotics in pancreatitis does not decrease any mortality or morbidity. It does not confer any mortality benefit. So be very confident, be very sure if you are in the first 72 hours to 1 week of pancreatitis, the increase in the fever, increase in the inflammatory responses or the shock or increased total count, your CRP, ESR is most of the time secondary to your SIRS response. So what if it is an infected necrosis? Definitely pancreatitis goes into a complication caused necrosis, which can be even a sterile necrosis of the pancreas or an infected necrosis of the pancreas. But infected necrosis of the pancreas usually starts from day 10. Or the necrosis as such starts from day 10, and there are high chances that the necrotic inflammation of the pancreas can become an infected necrosis. So for an infected necrosis of pancreas, definitely antibiotics are recommended, which is a grade 2A recommendation still. Serial measurements of procalcitonin may be valuable here. That is, an increasing trend of procalcitonin can definitely help us to guide that this is an infective response rather than inflammatory response. Or if you still think, no, this is not an infective pancreatic necrosis, this is just a sterile necrotic inflammation of the pancreas, then a CT guided fine needle aspiration and send it for gram stain and culture can always help you in confirming the diagnosis, but it is no more recommended because any injury to the pancreas might again inflame the pancreas all the more. So in a patient with infected pancreatic necrosis, antibiotics are recommended. Then which antibiotic to use? So here we should be knowing that there are only certain class of antibiotics which tend to penetrate inside the pancreas than using our regular cephalosporins, third generation, second generation cephalosporins. So only certain drugs do penetrate inside the pancreas. And what are they? So antibiotics penetrating inside pancreas are metronidazole, which has got a very good penetration inside the pancreas. Carbapenems, almost all the carbapenems, there is no study or no trial which shows that imipenem being superior to meropenem or meropenem being inferior to imipenem. Both of them equally penetrate inside the pancreas. Quinolones, especially ciprofloxacin and moxifloxacin. And when it comes to antifungals, azoles. The other drugs like eccridopenicillins and third generation cephalosporins have an intermediate penetration. But do remember that aminoglycosides and echinocandins do not have any form of penetration into the pancreas. So in a patient who is critically sick and you think that there can be a chance that there is a fungal infection, do not go into the blunder of starting an echinocandins thinking that it penetrates inside the pancreas, because other than azoles, especially fluconazole, there are not much antifungals which do penetrate the pancreas. So what bacterial infection do we usually see in pancreas? Usually are enterobacterials, GNB like E. coli, Klebsiella pneumonia, Proteus are the most common inhabitants we see in the pancreas because they usually tend to come from the gut translocation. Other than that, there are gram-positive bacteria like Staph, Strepto and Enterococcus are also commonly seen. Candida's infection is also seen sometimes in pancreatic patients, but always remember that if there is a Candida's infection in the pancreatic patients, then it is associated with a very high risk, almost around 40 to 50% of mortality. Among the Candida, Candida albicans is the most frequent fungi, followed by the Candida tropicalis and cruzi. And definitely, as said earlier, only azoles have the capacity to penetrate inside the pancreas, but no routine prophylactic administration of antifungals is recommended, because we have only azoles which penetrate inside the pancreas, and we want it to act definitely against our Candida species if at all it grows in the future. Then giving azoles prophylactically and making the Candida resistant to it. So these are my references. It is from International Association of Pancreatology, American Pancreatology Association, and World Society of Emergency Surgery Guidelines. Thank you.